Good evening, everyone, and thank you for joining us today. We are excited to have you all here for another wonderful patient webinar, Thyroid Eye Disease, Navigating Treatments and Advancements. My name is Gabriel Macias, Business Development Manager for Harvard Eye Associates. It is my pleasure to introduce our presenter for the evening, Dr. Connie Sears, Oculofacial Plastic and Reconstructive Surgery Specialist. Dr. Sears is an oculofacial plastic surgeon with expertise in cosmetic, facial, and reconstructive surgery. She earned her medical degree from Harvard Medical School and completed her residency in ophthalmology at Stanford University. Dr. Sears further specialized through a prestigious two-year American Society of Ophthalmic, Plastic, and Reconstructive Surgery fellowship at UCLA Eye Institute. During this fellowship, she gained extensive experience in eyelid, lacrimal, orbital, and reconstructive surgery. Dr. Sears, thank you so much for being here to host tonight's patient webinar.
Thank you so much for the introduction, Gabe. Hi, everyone. Thank you so much for joining today. It is my pleasure to discuss thyroid eye disease with a particular focus on some of the treatment advancements that have taken place in the last several years. So the goal of this talk is to identify and define what thyroid eye disease is, to talk about the patient population who develops this entity or condition. We will talk about the pathophysiology or the mechanism that drives a lot of the clinical signs and symptoms that patients with this condition develop. And then we'll kind of round off discussing some of the treatment options and particularly the recent advancements. So of note, thyroid eye disease, when you look in the medical literature, actually has a lot of different names. But for the purposes of this talk, I will focus on just thyroid eye disease, and we will refer to it as that condition as thyroid eye disease alone. So what is thyroid eye disease? Thyroid eye disease is actually an autoimmune inflammatory disorder that is often associated with Graves' disease. Not always, but most often. 90% of patients who develop thyroid eye disease have a history or diagnosis of Graves' disease where they have a history of high thyroid hormone levels. However, 6% of patients can have a normal thyroid level, and a smaller percentage have low thyroid hormone levels. Now, although 90% of patients who have thyroid eye disease have a diagnosis of Graves' disease, the opposite is not true. For patients who develop Graves' disease and hyperthyroidism, only 20 to 50% of those go on to develop thyroid eye disease. The numbers kind of vary depending on the literature that you look at. So in terms of the population of patients who develop thyroid eye disease, it tends to be much more common in women, so about 2.5 to 6 times more common in women compared to men. However, when men develop thyroid eye disease, it tends to be much more severe and longer duration. There is no ethnic predisposition, and the average age of onset is actually 30 to 50 years old. Interestingly, thyroid eye disease tends to present within 12 to 18 months of diagnosis of a systemic thyroid hormone dysregulation. And we have seen patients who have had Graves' disease or Hashimoto's disease and have been stable actually for 10 or more years and developed thyroid eye disease later in the disease course. However, the vast majority of patients develop thyroid eye disease really within 12 to 18 months of having a systemic thyroid hormone dysregulation. Radioactive iodine, which is a treatment for Graves' disease and hyperthyroidism, has been shown in the literature to exacerbate thyroid eye disease and sometimes trigger the development of thyroid eye disease in some patients. There is a really complex mechanism that plays a role in the pathophysiology and the activation of the inflammatory cascade that leads to all of the findings in thyroid eye disease. This inflammation or activation of inflammation leads to several different clinical features that are characteristic of thyroid eye disease. Now, it is important to note that there is no one lab that we can draw or blood level that we can draw that will diagnose thyroid eye disease. It is actually a constellation of clinical signs, symptoms, a lot of lab work where we look at different antibodies that might be produced, and also findings on orbital imaging. Now, one of the most characteristic features of thyroid eye disease is something called eyelid retraction. Eyelid retraction is when the upper eyelid develops an abnormal elevation where it sits in a much higher position. And there's a little yellow marker here where we kind of look at the center of the eye and see where that eyelid margin is sitting. And that's where the lash line is. Normally, that lash line should be sitting right at that border of the iris, and none of the white of the eye should be showing. Now, in thyroid eye disease, the eyelid becomes retracted and pulled up in that position so that this white of the eye is being exposed at all times. The other thing that happen is the lower eyelid can also become retracted, as you see in this lower picture. The eyelids can become really swollen and red, as you see here and on the third photo. And in terms of the ocular surface, you can have inflammation on the surface of the eye that leads to a lot of redness and something that we call chemosis. Chemosis is essentially an accumulation of fluid underneath that clear conjunctival tissue on the surface of the eye, and it can become quite uncomfortable. It can break down because the conjunctiva is exposed to more air than it's used to being exposed to. Now, the eye socket or the orbit contains the eyeball, but it also contains 6 extraocular muscles that are responsible for the movement of the eyes, in addition to fat in behind the eye. The activation of the inflammatory cascade in thyroid eye disease leads to the enlargement of these extraocular muscles and to expansion of that orbital fat behind the eye. Now, this leads to what we call proptosis, which is bulging of the eyes. The eyes look really prominent. And the reason is you have a very rigid, bony structure behind the eye, the orbit. And if you have enlargement of the soft tissue within that bony, confined space, the only direction that eyeball can move is forward. And so it sits in a much more projected or forward position than it normally should be sitting. The other thing that can happen is there can be expansion of the eyebrow fat pad and the dermis, which leads to this really full appearance in the periocular region. Fortunately, that tends to resolve on its own over time. Probably the most debilitating consequence of thyroid eye disease is strabismus or eye misalignment. In thyroid eye disease, the muscles that move the eyes become very hard, rigid, and swollen. And so these muscles don't contract and relax as they normally should when they are gliding the eye in movements, as in when you're looking to the left, right, up, or down. And so because the eye muscles do not work properly, they are pulling unequally in different and can lead to the eye being in a different direction or pointing in a different direction compared to the other eye. When the eyes don't line up properly, the brain actually receives 2 different visual stimuli, and this can lead to double vision. So in this patient in particular, the center photo here is of the patient looking straight ahead, and that muscle, the muscles on the left have become very rigid and enlarged and really pull that eye in an abnormal position looking up while he's looking straight ahead. The photo up here is of the patient looking up. And so you see that although in primary gaze or when the patient is looking straight ahead, that eye is pointing forward, it actually can't really elevate very much. But you see he's trying to elevate his eyes because the eyelid actually opens up more. On down gaze or when he's looking down, the right eye can move down, but that left eye, is really limited in how far it can move down. And then the same is true for looking left and right, that the the eye is really restricted and unable to move as it should. These constellation of changes in thyroid eye disease from all of the inflammation and the enlargement of soft tissue leads to all of the symptoms that are experienced by patients who are affected by this condition. So patients can have pain with eye movements, and a lot of that is due to that rigid, thick muscle behind the eye. They can develop double vision, as we discussed. They can have dry eyes because the eyes are projected in a forward position that they normally are not, and so they're seeing a lot more air and exposed to the air more than they should be. So people develop a lot of dryness. They can develop proptosis, as we discussed, light sensitivity, a lot of tearing, foreign body sensation, eye redness, and just a generalized discomfort. Thyroid eye disease, interestingly, has a very short-lived and limited active phase. This graph here shows the severity of the disease on one axis and duration of the disease on another axis. And relative to other autoimmune conditions, which tend to be, kind of flare up in activity throughout someone's life, thyroid eye disease has a very short-lived phase of activity where the active phase tends to last anywhere from 12 to 18 months, where you have an increase in activity that plateaus, that activity decreases, and then um, the the uh, the activity actually becomes quiescent or inactive after a certain amount of time. And that's with or without treatment. It essentially burns out on its own, which is, again, atypical for autoimmune conditions. One key point to note is that smoking is actually one of the only modifiable risk factors for thyroid eye disease. Studies have shown that there is an increase in severity and duration of thyroid eye disease in patients who are active smokers. So I really counsel my patients, if they're current smokers, to cut down on the smoking and, if possible, to avoid it altogether. When we treat the active disease, the goal is really to decrease that inflammation to make the individual much more comfortable and to decrease, hopefully, the active window, whereas hopefully we can shorten that 12 to 18 months to much less activity. When determining how to treat thyroid eye disease, we really think about the stage and grade of thyroid eye disease. And in terms of the stage, we think of, is thyroid eye disease active or inactive? And in active disease, we further subdivide it into mild, moderate, and severe. And it's really the stage and grade that guides our treatments for patients. And so what I mean by that is, if someone has mild thyroid eye disease, thyroid eye disease has a very wide spectrum. There are some patients who have very mild disease, some patients have more moderate disease, and some patients can have severe thyroid eye disease that can be vision threatening. So if someone just has mild inflammation of the surface of the eye, we really focus on more supportive treatment. So we rely on artificial tears to improve the lubrication from all of that exposure from the eyes being more open and more proptotic. We also can use topical steroid eye drops to help with that surface inflammation. And there were studies that showed that selenium supplementation actually can decrease the risk of developing really severe thyroid eye disease. For moderate to severe thyroid eye disease, we rely on more systemic treatments to decrease the overall inflammation within the body. And so these include oral or IV steroids. However, we really try to avoid steroids because they have a lot of adverse effects or side effects, including, increased blood sugar level, stomach ulcers, weight gain, anxiety, high blood pressure, a lot of things that a lot of adverse effects that we really try to avoid. So we really only use oral and IV steroids when absolutely necessary. There was no perfect treatment for thyroid eye disease, and for a long time, we really relied on these imperfect treatments, including the steroids and rheumatologic medications that were used for other autoimmune and rheumatologic conditions, including rituximab and tocilizumab. Unfortunately, these didn't really provide great or consistent improvement in thyroid eye disease. Some people responded, some people didn't respond, and very often a lot of patients just had a partial response to the decreased inflammation. In terms of orbital radiotherapy, this is a treatment that is targeted just towards the inflammation in the orbit, but the literature is kind of contradicts itself. Some studies show that the orbital radiation helps to decrease the inflammation, and other studies actually show that there is no improvement in the orbital inflammation. All of these treatments, with the exception of the orbital radiotherapy, are very nonspecific. So they target the overall inflammation and the overall inflammatory cascade within the systemic body as a whole, and not specifically for thyroid eye disease. One exciting advancement in the treatment of thyroid eye disease is the FDA approval in 2020 of a new medication called Tepezza, or teprotumumab. This medication is the first medication that was approved by the FDA specifically to treat thyroid eye disease. It is a monoclonal antibody which uh, which targets and inhibits one of the receptors that is upregulated in the soft tissues within the orbit in thyroid eye disease. And so um, patients are required to obtain IV infusions of this medication every 3 weeks for a total of 8 infusions. Interestingly, when the studies were being done, the clinical trials showed that patients who were treated with Tepezza had a substantial improvement when compared to patients who were treated with placebo. And so this was really an exciting advancement because it was the first time that there was a treatment specifically targeted to the inflammation that happens in thyroid eye disease and not to the overall inflammatory cascade that is very nonspecific. However, Tepezza has a lot of adverse effects. And so one thing to keep in mind, and what I really counsel my patients is, the most common adverse effects are GI symptoms. So nausea, vomiting, muscle spasms, diarrhea, and there can also be an increase in blood sugar. Side effects are very common with Tepezza. However, most of them are mild and reversible. Most patients experience 3 or more side effects. And the most common reason for discontinuation of Tepezza prematurely before the completion of all 8 infusions was hearing loss. Some patients developed permanent hearing loss that required the use of hearing aids after starting Tepezza, whereas they didn't use hearing aids previously. So for all of my patients that I start in Tepezza, I actually get a baseline hearing test to ensure that they don't have any significant hearing loss that they're not aware of that would put them at an increased risk of further hearing loss with Tepezza. So this is really an important discussion to have with patients. And one of the discussions I have is, we can think about the current disease state. So if they're having moderate or severe symptoms, and decreasing the disease activity, and really what that means in terms of the adverse effects. Again, most of the patients who were started on Tepezza developed side effects, but they were tolerable and they were reversible when the infusions were discontinued. One key or important um, development that can happen in thyroid eye disease is something called dysthyroid optic neuropathy. So as we discussed, all of the soft tissues behind the eye become enlarged. And what can happen is the optic nerve, which is the connection or the cord from the eye to the brain, can become essentially strangled with all of that inflammation in that confined bony space. And when the eye is pushed or propelled forward, it can put that cord on stretch and lead to permanent damage of the optic nerve. This can be vision threatening with the potential for permanent vision loss. So this is really an urgent entity. The treatment options are surgical decompression, where we go in and actually make more space within the orbit to allow that eye to fall within that space, so that that optic nerve is no longer on stretch. We can use IV steroids, where we actually treat with very high dose IV steroids. And one of the options also is Tepezza. There were a few studies that showed that Tepezza actually decreased the inflammation rapidly in all patients with thyroid eye disease, but that becomes particularly important when someone has developed a vision-threatening eye disease, thyroid eye disease. And so it is imperative to decrease that inflammation as quickly as possible so as to mitigate any permanent damage that can happen to the optic nerve. And so, we have a few options for this condition, and again, the key is really urgent treatment of that. With the advent of Tepezza and disease-specific treatments, there has really been an explosion in clinical trials targeting specific antibodies or producing specific antibodies that target what is actually upregulated in the disease rather than decreasing or immunosuppressing the entire immune system. And so, for instance, one current clinical trial is instead of using the IV infusions, Tepezza is being trialed for subcutaneous administration. And what that means for patients is they'd be able to inject the Tepezza in the comfort of their own home subcutaneously. And so this is kind of similar to someone injecting insulin who has diabetes. So that's currently being studied now. We have to figure out certainly, the dosing that makes sense and that is actually effective, and whether this is a safe option or not for patients. There are other subcutaneous treatments that are currently in the pipeline and in clinical trials from different pharmaceutical companies. And there are also other antibodies that are being produced and trialed currently in clinical trials. And then there are also other antibodies that are not necessarily directly targeting the inflammation in thyroid eye disease. These tend to be medications that are used for other autoimmune conditions that they're trialing to see if they are effective in thyroid eye disease as well. So that was really a focus on the treatment of thyroid eye disease when it is in the active phase. And again, we really take into consideration whether it's mild, medium, moderate, or severe, and including vision-threatening disease. But when someone has that inflammation burn out and they are now in the inactive phase of the disease, the treatment actually revolves around periocular or periorbital rehabilitation. So a lot of the times, yes, the inflammation burns out, but these long-term effects can persist, including the proptosis. The eyes don't always fall back into place after that inflammation goes away, because that orbital fat can be permanently expanded. The muscles can become very large and stay that way. The other thing that can persist is the eyelid retraction and the strabismus, or the eye misalignment. When the muscles get very large and rigid, they have a hard time relaxing back to the state that they were in prior to developing thyroid eye disease. When we focus on periocular or periorbital rejuvenation, we do this in a stepwise fashion and always focus on the decompression first. If someone needs that orbit to be decompressed again, to make more space within that bony socket so that eye can fall back into place, to be recessed to the closer to a position where it used to be before the patient developed thyroid eye disease. The next stage after that eye is returned back to its normal position within the orbit is to address the eye misalignment. And so the eye misalignment tends to happen second, and the eyelid malpositions are addressed last. And the reason is, when the eye misalignment is addressed, it can actually change the eyelid position. So it's really important to do to proceed with the rehabilitation in this specific order so that we can address everything appropriately. So, a few take-home points for thyroid eye disease. It is a clinical diagnosis based on the constellation of signs and symptoms. Again, there is no one lab value that diagnoses thyroid eye disease, unlike diabetes. Thyroid eye disease typically occurs within 12 to 18 months of systemic diagnosis of thyroid hormone dysregulation, whether that's high thyroid or low thyroid. Again, the majority of people have a high thyroid or a history of high thyroid level or Graves' disease. The management and the treatment is really based on the stage and the grade of thyroid eye disease. So again, whether it's active or inactive, and when it's active, really focusing on the symptoms. So if someone is mild, has mild disease, moderate disease, or severe disease. And then in the inactive phase, really providing that rehabilitation to bring those eyes back to the position where they previously were, bring the eye misalignment back, and also bring the eyelid malposition back to where it used to be. And there is importantly, a huge paradigm shift in the management of thyroid eye disease, where previously, historically, we really relied on non-specific treatments, including, the high oral or IV steroids and the rheumatologic medications that were intended for other autoimmune diseases, to now a more targeted medication approach, so that we can tailor the medications to specific disease processes. So I'd like to thank you all for joining. If you have any questions, I'd love to answer them now. And if you have had a diagnosis of any thyroid abnormality and feel like you're developing new eye symptoms, whether it feels like you have kind of a gritty sensation or more dry, or if you feel like your eyes appear more prominent, please schedule a consultation. I'm happy to take a look. Thank you so much for your time.
Okay, it doesn't look like there's any questions, Dr. Sears.
Okay, well, thank you everyone for joining. I think someone had raised their hand, but I'm not seeing any questions here.
Hi,
Yeah.
for those who have their hands raised, if you would like to input your question into the chat box, Dr. Sears would be happy to answer.
Well, thank you everyone for your time. I really appreciate you coming in and listening to my talk.
Thank you so much, Dr. Sears, for the presentation. And once again, thank you to all of our guests who attended. If there are any questions that do come up after this evening, please feel free to email marketing@harvardeye.com. And we hope to see you at our next webinar event. Have a great evening.